Good morning, everyone, and welcome to colleagues in the room and to everyone online. My name is John O'Connor. I'm joined today by Professor Mark Boyle and Sean Fowlu from the Social Sciences Institute at Maynooth University, who together with the Research Development Office of the University bring you the Research for Policy seminar series. None of this would be possible without our production team of Anne Hamilton-Black and Orla John. Regular followers of the Research for Policy seminar series will know that we bring together researchers and policymakers interested in how research-based evidence is generated, shared, and used in policy, public policy and practice. Our lens when looking at the topic is to think in terms of systems. So we see three domains in the space: a demand for evidence, a supply of evidence, and intermediary type activity, sometimes known as knowledge brokers or knowledge mobilizers, that work to connect or strengthen the connections between evidence and policy making. Today, we're going to try and cover off the three domains of demand, supply, and knowledge and mobilization and brokering. And we're going to try and do that in the context of health and social care policy in Ireland. Health policy and related areas of policy are often seen internationally as having the most developed systems and structures for bringing research-based evidence into decision-making processes. And we also see, in terms of the scholarly work on evidence for policy, a significant majority of systematic studies on evidence for policy are done in the field of health policy. To help us join the dots today in the generation, sharing and use of evidence in health and social care policy in Ireland, we're delighted to be joined by three expert panellists. I'm going to introduce them in the order that we've asked them to present their opening remarks. First up, we have John O'Neill, Head of the Research Policy and Innovation Unit in the Department of Health, which was established in 2024 to ensure the crucial contribution of research and innovation to the wider health system improvement is more fully exploited. His specific responsibilities include supporting a research-led approach to the health service executive and providing strategic direction and corporate governance for the Health Research Board. John's going to provide us with a Department of Health perspective on evidence for policy, outlining the key structures and processes the department have established to generate and use evidence. And he's also going to speak about the challenges and opportunities as that department seeks to further strengthen its capacity for evidence-informed policy making. Welcome, John. Next, we're going to hear from Teresa Maguire, Director of the Research Strategy and Funding at the Health Research Board, where she's responsible for all Health Research Board research funding programs, partnerships, and collaborations. Teresa has experience of working with numerous health policy and practice partners to both prioritise and specify evidence gaps and to design research calls to address them. Prior to taking up her current role as Director, Teresa spent almost 5 years on secondment of the Department of Health to support the establishment of new research services and policy unit, tasked with supporting evidence-informed decision-making in the department and advancing a broad-based health research strategy. Today, Teresa is going to speak about the different types of evidence that the Health Research Board supports and its work in building some capacity to be able to produce the necessary evidence. She's going to highlight the importance of evidence synthesis, which brings together the best available and most reliable evidence based on systematic reviews. Welcome, Teresa. Our third speaker today is Barbara Queenan, a Senior Research Fellow at Evidence Synthesis Ireland based in the University of Galway. Barbara has over 15 years' experience in health research. Evidence Synthesis Ireland at the University of Galway hosts the Cochrane Ireland, and it's a very interesting organisation, recognised as a National Centre of Excellence in Evidence Synthesis, not just conducting evidence synthesis, but promoting awareness and use of evidence synthesis in decision-making, and also developing national capacity to undertake high-quality evidence synthesis. And increasingly, Evidence Synthesis Ireland, I think, and that types of methodology are seen as essential for many decisions in policy and practice across a wide number of policy fields, not just in health. Today, Barbara is specifically going to speak about a systematic assessment of the evidence support system in health policy that she has led, and which examined how evidence is produced and used to inform health policy in Ireland. We think this is a really significant piece of work, not just in terms of the methodology and the findings, which are really interesting themselves, but because evaluation is seen as central to learning and improvement and ultimately to institutionalizing evidence use in public policy. So I'll combine them. So over to you. After all three of you have spoken and given your initial remarks, we'll go to the floor. So you're online, please add questions, comments, ideas, observations into the chat facility, and in the room, be ready to engage with really a great panel of experts that we have today. So first up, I'm going to ask John. John, the floor is yours.
Thanks, John. Thanks for the invite to be here this morning to kind of talk about it, I suppose, from the kind of what John was talking about, but from the departmental point of view. So I suppose maybe kind of the demand side, as John mentioned. So the unit that I work within is the Research Policy and Innovation Unit. It's about maybe kind of less than 2.5 years, so it's relatively recent in that context within the department. And I just wanted to kind of give a kind of a sense of, and Teresa would have been involved in kind of some of these areas kind of when she was in the department, but just to give a sense of kind of how we're set up within the department on the research side of things. So we actually have kind of 3 units that are really kind of focused on kind of research. We have the Strategic Research and Evaluation Unit, and this is really kind of where kind of it's more kind of, I suppose, of an internal kind of focused kind of policy unit, which is trying to kind of, I suppose, kind of address issues for a lot of the policy units, and that kind of obviously kind of works through the evidence synthesis services, which is in the HRB, but also kind of trying to look at kind of productivity levels, kind of, you know, within the health service itself, looking at kind of all the facts and figures. So it's very much about the health system itself, how it's performing, KPIs and so forth, and kind of and trying to kind of see how that impacts then on the policy side of things on a day-to-day basis. And then we have obviously the Statistics and Analytics Unit, which again takes a lot of the information and kind of shows or demonstrates then kind of where the performances are not, maybe on the KPIs in that regard. But again, I suppose maybe just to stress that both these units are kind of very much kind of internal within the department, with a very strong internal focus in terms of the operations side. And then we have the third unit, which is my unit, which is, as I said, it's only just after, I suppose, just over 2 years old. And I think it's probably fair to say this is much more of an external facing unit. So it's about kind of being much more kind of, I suppose, kind of engaging with academia and engaging with industry, the clinical service. So it's a much kind of more expansive kind of maybe kind of role in terms of kind of interacting with other government departments and agencies across the whole of government, but that wider kind of landscape and ecosystem as well. So obviously we work very closely with the HRB, kind of on the evidence for policy side of things. We work really closely with the HSC, and they're kind of centralised and regionalised, kind of focused on research and innovation. But we also kind of have a lot of work ongoing within the unit around clinical trials, genomics, and this is where that kind of interaction with the clinical kind of academia and the industry really kind of comes to the fore. We're also heavily involved in the Impact 2030, that's the HRB, in terms of kind of that wider kind of research agenda for government and how we prioritise what we're looking at. And that's interesting from the point of view of bringing climate into other conversations around policy and so forth. And maybe just to mention as well, kind of obviously we have a kind of a fairly strong role in terms of the EU presidency, particularly on the biotech file, so which is going to be kind of all consuming kind of in a matter of weeks. So that's just to give a kind of a bit of context of kind of how we are. I've just kind of put something up about the current landscape, and this isn't kind of everything, but it's just to give a sense of kind of where we kind of operate within. I mentioned before about the evidence synthesis service kind of that we kind of interact with within the department with the HRB. And I remember before joining the department and when I was in other government departments, we used to go in the odd time into the Department of Health, and we were really jealous that there was this actual service that you could nearly kind of call on, which was the evidence synthesis service, where you could kind of do kind of lit reviews, you could do international reviews, and you could do it really, really quickly or relatively quickly compared to kind of other government departments who kind of just didn't have that kind of interaction. So so I think that kind of is a really key piece. It's kind of and it's one of the units that kind of within the department that kind of deals with that. And then obviously we have the ESI, which was mentioned, and Barbara will be kind of talking about kind of rest of kind of later, so I'm not going to say too much, but that's a key part of how we look into kind of informing kind of methodologies into the future, and I'll come back to that. We also within the department kind of policy units would commission maybe other kind of parts of kind of work that would be research kind of in particular areas, which would be kind of directly commissioned by some areas of the department in terms of what they needed to do. And then the evidence and policy piece, I think, is really kind of key. And this is something that we're kind of with the department and the HRD was developed in terms of a pilot of kind of trying to see how we can kind of link the policy units closer to the research side in terms of what their research questions were and trying to do work on that. So we've had 2 rounds of pilots to date on that, and we're working very closely on kind of next steps around kind of what the learnings from that are. So I just put this up with a very simple diagram. I didn't want to kind of spend too much time on it, but I just wanted to give a sense of kind of maybe kind of within the overall landscape kind of where we work. And this is probably something similar of a challenge maybe for kind of other government departments and challenges for the research community, actually, kind of more than anything else. It's kind of how we kind of operate within this kind of flow of kind of where, you know, kind of we're kind of moving from the policy department demand led, let's say, kind of what they kind of are the key policy questions that we need to kind of look at. And that could come through us as an intermediary for another policy unit, or it could come direct to the HRB, for example. And then that kind of is translated onto the research community. And often I think kind of what happens kind of, or what can be potential to happen is that sometimes the research question might get slightly lost in that translation. The potential for that to happen is there. And this kind of is a kind of full cycle. It comes back on itself as well. So it's kind of that interaction between kind of all the players that are there, and how we communicate this. So kind of from the point of view of the department, are we communicating really clearly on what the research question is? Kind of is the research community understanding what that is, and being able to kind of think about it from the point of view of how the research can be carried out to address that question. And oftentimes kind of probably one of the key challenges, but this is again across government, is kind of probably around kind of making sure that that is understood more clearly between policy people and the research community. And it's been there, that challenge has been there for kind of a number of years, but it's something that we do need to continue to kind of look at in terms of kind of how we might address that. So I think this is just to kind of give a context of, in a very simplified form, but just to kind of say that kind of there's probably lots of kind of gaps in here, or potential gaps in here, where some of kind of what we're trying to do might get lost in the overall mix of the communication of what we're trying to do. And it's trying to kind of close those gaps, I think, is kind of part of the kind of challenge, and really get to kind of what the key questions are and how we answer them. Another, I suppose, kind of big challenge for, and this is kind of very current at the moment, is the whole timing challenge. And again, you've probably kind of heard quite a lot about this in terms of evidence policy. Working in the policy area, you know, there's often a kind of a strong demand for kind of, no, I want the answers now, you know, and I can't wait 2 or 3 years, or kind of, you know, I can't wait 6 months or whatever it might be. But there is this kind of, I think on the policy side, we need to be thinking more from a strategic foresight point of view. So you're kind of looking forward in terms of policy and legislation and what you need to think about. And that's your longer term planning, and being able to align that with the research questions that might be able to inform that is kind of a challenge in itself, but it's something that we need to kind of look at kind of more. And then I suppose kind of with that more immediate kind of challenge, how do we address that, where kind of there's a kind of a constant demand on kind of questions being asked wherever that might come from, but from the policy side, how do we change certain things? How do we amend kind of maybe legislation or whatever it might be? How we respond to kind of the political system in kind of that regard as well. And how do we make sure that there's an evidence informed policy decision that kind of follows that? And kind of when I say weeks, I do mean weeks, and I think we can come back to this and kind of, and obviously we'll talk about the rapid evidence kind of products, which kind of are really interesting in that regard. So just to give a sense of the time kind of challenges in that regard. So for us, I suppose kind of, again, on the communication side of things, that need to communicate what are and be really clear about think about kind of maybe kind of how we do that, kind of moving forward. And, sometimes it's difficult to kind of be really clear on that 100%. You're going to really have to leave some scope kind of for being kind of adaptive to kind of what might happen kind of over, let's say, the lifetime of a government in that regard. Spoke about the interface between the policymakers and the research community. How do we kind of bring that closer? How do we kind of make sure that both kind of communities understand each other really clearly on kind of what those kind of demands are, what the constraints are on both sides, kind of, and how we can kind of bring that kind of bring both kind of closer together. This is one that's kind of probably for me a really, really key one, and kind of has been for a long time. It's kind of how do we actually then, once we get the evidence, or once we're kind of producing the evidence, how do we actually make sure that that gets into the policy? How do people know what the evidence is? How do people kind of access it in a way that actually makes it easier to kind of actually get it into the policy making? And this is kind of, I suppose, a really kind of key challenge around trying to do that. And part of that maybe is interrogating the existing evidence. So we've kind of been talking, there'll be a lot more talk about that, about kind of centralized systems and so forth as well, and kind of what we might do. Avoiding duplication is kind of a really big one as well. And then obviously kind of, we do rely an awful lot on informal networks, and kind of, I think Barbara will probably talk about this later as well, but kind of how we, kind of, it's all about people at the end of the day, and kind of the connections we make, and kind of who we have those relationships with is where maybe kind of a lot of things might happen. But how do we make it institutional and kind of easy for the system to kind of grasp, rather than just kind of through these particular networks? So just to maybe kind of mention a couple of things, I'm not going to try and steal any thunder here, kind of on Teresa, but just kind of we've been obviously kind of working with the HRB, and we kind of work really closely with them and Teresa and the team. But this idea of kind of also kind of working with Evidence Synthesis Ireland around the rapid evidence products, so kind of which is a really interesting concept. This idea that you can kind of actually say, okay, let's try and see what's currently out there, kind of. And I'll come back to this, and kind of how we collate and condense or distill that information into something that can be kind of actually understood and usable by the policy side, kind of with the caveats that it's been kind of done within a couple of weeks or 2 or 3 weeks, and what that means as well. And at the moment, obviously, kind of we have there's kind of a lot of work going on about kind of an evidence synthesis hub within kind of the HRB, which is around health security threats and all that, and that's where that rapid evidence synthesis really comes into its own, kind of, and we don't need to say too much more about that, but that's kind of key. Just one small thing that we have been doing as well, just on the Tilda kind of project is, and this is again trying to do that rapid piece as well, maybe kind of where we're trying to get the policymakers to sit down with those who have the data, and maybe asking, from the policymakers, is there questions you need to interrogate here with the actual data? So bringing the people from Tilda together with the policymakers, and just trying that out and trying to see if there's a kind of piece of the work that we can kind of do that. That's kind of something we've been doing recently as well within the department. So just maybe just to mention this thing about the kind of the rapid evidence support side of things, which I think is really exciting in terms of kind of where we might go to next. But it's this thing about being agile and responsive, which I kind of spoke about before, which is really good. It's the existing evidence. However, the potential limitations obviously kind of around this as well is kind of how we think about, okay, kind of this is rapid evidence informing policy. So how do we communicate that to make sure that the policymakers and the minister or ministers kind of understand kind of that this is kind of based on, a best decision on the best available information, or how you might kind of want to communicate that. I think it's really key that we kind of understand that we can, and that we communicate that clearly when we're kind of looking at these particular products in that regard. But there's no question that there's huge potential here to kind of actually kind of inform the overall system a lot better than we can do at the moment. Just wanted to mention this, and you could probably have a separate session on this, but I did say at the start that our unit deals an awful lot kind of with kind of the clinical side and academia within that regard as well, and industry. And this is very much around things like clinical trials and genomics. So it's actually kind of clinical care, but it's also research and kind of planning for research in that regard. So there is the evidence for health policy, so which I've just been talking about, so how me sitting behind at the desk trying to get information, so I'm thinking of a new policy. But then there's also the kind of working with colleagues in the HSE and elsewhere, how kind of the evidence for clinical care gets into the system and how that's taken on board. And there's lots. I mean, that's around all the different innovations and research that's done around medicines, medtech, whatever interventions that we're looking at. How does that actually kind of make it into the health system? And that I suppose the evidence that's there is quite different because it's actually informing services rather than the actual kind of policy side of things. But it's a really key one. It kind of speaks to things like implementation science, which we could kind of spend the rest of the day talking about. But I think it's just important to note just that is kind of part of it too, and that there are kind of several layers. And I think that's it. That's me. Thank you.
Thanks, John. That was a great introduction. And John mentioned the health research board a few times on evidence synthesis, and it's great the department has its own research funding organisation to really kind of manage the supply of the relevant evidence and to be matching that evidence for the knowledge gaps the department has in our policy. So Teresa's going to talk us through some of the work of the health research. Thank you, Teresa.
Morning, everybody. Just still morning online and in the room. And thanks very much for the invitation to talk about, I won't say showcase, but to share our insights from a health and social care perspective. I'm Teresa Maguire and I'm Director of Funding, Strategy and Funding with the Health Research Board. So as John said, I look after many different funding programmes. But also there are elements that I will talk about that relate to other parts of the Health Research Board, which also has a long-standing history and track record in providing data for policy and planning in areas like mental health and drugs and addiction and so on, and more recently the Evidence Centre. So it's just important to say that I'm speaking on their behalf as well. I suppose just to come at it from a slightly different perspective, which is really what we're trying to do today in the health and social care space, is, I suppose as a funder or as an organisation like the Health Research Board, I just want to sort of share some insights in terms of things that I think that we're doing, maybe things that I think that are working well, things that are rapidly evolving, and maybe some areas where, we have been maybe slightly behind, other countries are catching on. But the most important thing that I want you to take from today is that, speaking from a health and social care perspective, but everything that I touch on, I think is completely and utterly transferable and generalisable to any other sector or any other player, whether you're a researcher, a policymaker, or somebody in between that's struggling to find a name to describe yourself in that space. The first point that I want to mention, and then I won't dwell on it, I'll move on it and move into a couple of specific areas of kind of evidence that we really, really focus on trying to drive and put into the process and get adopted, is all of us as funders have a role to play in the evidence for policy system. That's not the totality of the reason for funding research, but you earned a right to try and mobilise, connect, and catalyse your community for evidence for policy if you have the capacities, the capabilities, the connections, the networks, the infrastructure in your research systems. And that's just a shout out, because I think sometimes in an evidence for policy discussion, sometimes we can forget you earned a right to have these discussions and to do this work. And we know that Ireland is under investing for a long, long time in research and development. So I'm just going to get that little shout in there because that's important to say. And in doing that, in everything that we fund, and me, John's mentioned trials and Tilda and cohorts and all sorts of things. When we do that, it's important that in readiness and in thinking about the evidence for policy space, things like driving interdisciplinary, transdisciplinary, and indeed transsectoral approaches are really, really key. So when we fund people right from PhD level, we're thinking about the skills, the conditions, the soft skills in particular that will allow people to work well in that space across whatever boundaries they're going to be working in. The mindset and the skill set to work with public patients, those with lived experience, and to bring that into the research, and decision makers, whoever they may be. And that may be somebody sitting in the HSC, it may be somebody sitting as a manager of a nursing home in health, it may be somebody sitting in the Department of Health. That's really, really important. And also the reason why we constantly look out, John mentioned the EU presidency, all Ireland, EU and international more generally. It's really, really important that we promote and support people to look up and to look out and to participate in international research, because at the end of the day, for policy making, I think you'll see, it is the combination of national and global evidence that is really that you're using to inform your decision making, and I'll touch on that a little bit today. But for the purposes of today, I'm going to mostly focus on evidence synthesis and on the data and modelling side of things, because in my 20 plus years of working in this space, particularly when it comes to the agenda setting or trying to figure out what my question is, what program, service or policy, how do I go about it, what do others do, what's my starting point. These are the evidence forms that we most commonly are requested for and are valuable at that summit. Now, another day, I think we'll have a whole separate conversation about evaluation and maybe the paucity of evaluation feeding into decision making, either in terms of what to disinvest in or maybe what to start or what to change. So that's maybe a shout out for another day. I won't dwell on this too much, other than to say John's already touched on it. I suppose 20 years ago when I was in the HRB, I was very aware that in the health space there's a long tradition and history and culture of evidence-based medicine, which is very, it's looking at patient level decisions. It's predominantly still trials evidence, and John has touched on that, although even then that's moving more into pragmatic trials, trials and real world data. So actually even in our trials team, which we would see more as being evidence-based, maybe medicine or practice, that world is changing around us as well. Whereas evidence-informed policy is very much at the systems, at the policy, at the outcomes level. And that throws up additional requirements in terms of data and in terms of evidence. You now need economic cost data, feasibility data, acceptability of the public, access, who will access this, equity issues, the implementation context that John mentioned. And the time horizons, again, are very different. They're less about sort of 5-year programs and more about what do we need within the policy timelines and within political windows. And context is key. I think context, as I said, is becoming increasingly key, even in the trials and intervention space, but certainly when you move into this space, things like equity, timeliness, acceptability, do you have the workforce, all of these things become really, really key. One of the reasons that we funded access to Cochrane for everybody on the island of Ireland more than 24 years ago was because one of the things that is shared in this is actually a systematic approach to going about thinking about the evidence you want, compiling it, transparency, and an ambition that somebody else can interrogate it and maybe reproduce it, and the use of synthesis and critical appraisal skills. And over the last 20 years or so, this has led to us funding initially Cochrane Ireland, now called Evidence Synthesis Ireland. And if anybody isn't aware of the work of Evidence Synthesis Ireland, this is my opportunity to say, look them up. They are absolutely fantastic. We have never funded them to do copious reviews, but we have them to raise awareness, to promote, to do introductory training, so that at a minimum people know what a review is, how to read it, how to appraise it, to understand its limitations, and then opportunities through fellowships to actually conduct reviews at different times. And really, I'm not going to go through this in any detail. I want you really to take it away with you. And in truth, Evidence Synthesis Ireland have much better resources than I've put up here, because this is not even a fraction of the types of reviews that are now being used to support decision making. The traditional one is systematic reviews, and if anybody has been into the Cochrane Library, you will see that typically would take 9 months, maybe over a year, to do a systematic review. Really, really rigorous, tended to be on RCTs, meta-analysis, forest plots, and so on. And so, but from a policy perspective, not really hitting the mark always in that it didn't cover things like implementation, acceptability, equity, and context, and so on. But generally, it was like, this is too slow. We can't, we can't wait over a year for this. What we find in our own HRB Evidence Centre is that probably the most popular, say by demand, type of review requested is a scoping review, which is if you're as a policymaker thinking, I'll give an example, many years ago, it was, the programme for government said, we've got to launch a new home care scheme in Ireland. If you're sitting there as a policymaker, you go, right, okay, how do we start? Where do we start? What do other countries do? What do other countries similar in size to Ireland do, and with our demographics? Who's covered by home care? Is it just older people, or is it more? Who's going to pay for this? What do countries who don't have social insurance do? What's the workforce? Do we have them already? Do we need a new workforce? How is this going to interact with nursing home care? Do you transition from one to the other? Just using that as a very tangible example of the type of thing that a scoping review. It's not a systematic review. It's not looking at every single piece that's ever been published in the world. You're focusing then maybe on specific countries, focusing on specific maybe funding models in a country, and the next point from that is usually that the policy unit are able to articulate the real questions they have, which often then leads to data analysis. So just useful to understand the different types of reviews. There's realist reviews, there's various other reviews I don't even have mentioned on this. What I think it has shifted. Systematic reviews, important to say, they still have their place. They're not redundant. They're really critical. They're as critical as they ever have been. But there is now an evolution and an expansion of the types of reviews. I will come back to rapid and living reviews in a minute. John has already touched on them. That's where there's massive demand, and particularly with AI, people going, I want a rapid review. And so I'll touch on that in a little while. But important just to understand the pros and the cons, and maybe some of the trade-offs that you have when you're in this. And that's okay, because you may make decisions on the basis of speed or on the basis of format. But as long as you have, and I think this is where Evidence Synthesis Ireland in their training and in their promotion and in their tools and the resources are really critical aids to the community. It is about ensuring that you're using robust methods. It's about ensuring that you use some of the very internationally recognised and the constantly evolving quality frameworks, and that you're transparent in what it is and in what it isn't. And again, I'm not going to go through this, but there are many known steps that you can take when you're working with different types of reviews, and particularly if you're moving to the more rapid reviews, or indeed even starting to think about moving to a living synthesis. There are things that you can do, you should do, and are internationally recognised as needs to do in order for this to be credible and for it to be useful. So I think it is about stepping back, knowing the context, the question, the timeline, making a decision, and then knowing that you can wrap various tools around that, like maybe a risk and bias tool. And GRADE is a well-known quality framework that is used for reviews, and would be expected to be the norm. And indeed, CERT when you move into qualitative. People have always said, well, it's very hard to do that in qualitative, but there are frameworks out there. So I've mentioned the move, the push, particularly with AI, into AI-enabled products. Then they can be faster, they can be speedier. We don't want the other ones, we'll have these. There's huge opportunities here for AI to support evidence synthesis. They can accelerate screening, extraction, updating, and so on. But it is important, and I think you notice in all research that you're involved in, that it is evaluated, it is validated, we have audit trails, and in particular, when looking at synthesis, when we're synthesizing all of the available evidence, that we are aware of things like bias, in the data, whether that be geographical, whether it be cultural or otherwise, and that we check for this and for equity safeguards. Let's not give a rapid AI-enabled review to support decision-making in the global south if all of the evidence that exists is from, Western Europe and the States, for, a completely different population. But importantly, my response here is that it's not a case of don't join the movement. It's about actually get involved, and I'm pleased to say that Ireland is involved, and the HRB is supporting Ireland's involvement and Evidence Synthesis Ireland's involvement in a very particular initiative called the Evidence Synthesis Collaborative. It's led by Welcome, but it is an open, inclusive invitation into any and all funders and indeed organisations who would be either evidence producers or intermediaries to come and join this collaborative, where it is about looking at the infrastructure regionally or sectorally and the open data systems and the methods and the evaluation criteria that will help us all to understand how we progress AI-enabled reviews with evaluation and validation in there by design, and importantly, with humans involved in the process. So it's human-centered, human-driven, AI-enabled products, but recognizing there is something hugely attractive about the concept of rapid products and living reviews, where literally as soon as something is published, it becomes integrated into a review. Now, there's a bit of a paradigm shift here, and I'm sure for a lot of people working in the review space and maybe in the evidence synthesis space, some people will be going, does this mean we're not needed anymore? And we don't know, but it's better to be on that journey and part of that journey, and to be part of the evaluation and the validation of how AI can help, but also not sort of bias or make the system even more inequitable than it is at the moment. And I suppose I would just encourage you, I won't go into a lot of detail on it, encourage you maybe to look up the Evidence Collaborative website, which is now, for the first year, like everything in setup, it talks about what it would like to do. But there are very real things at the moment that you can join into in any sector. This is not just health. We're in it looking at it with a health lens. And some of the sectoral hubs that they are looking at, one in mental health, Welcome is leading that. They've already got a flagship evidence repository called Galenos, worth looking up if you're interested. And some of you may be aware that in recent times, the UKRI, through all the acronyms, the Economic and Social Research funding body ESRC, has contributed 11 million to establish a project that they've called METIUS, METIUS, and that is looking at climate change, justice, education, and international development. I'm sure I've missed one of the things in there. And importantly, through an open call, and this is about connecting anybody who's interested in these areas, both on the AI side, on the evidence synthesis side, and on the policy side. This award is led out of Queen's in Belfast. But my other partners are UCL. So really encourage you to take a look at that, because they're driving that. And we're hoping that the next sectoral hub, building on what John has spoken about, and we've now set, I'm going to call it a regional hub and spoke for rapid evidence synthesis, working with the Chief Medical Officer in the department on preparedness and response. Will it work? Perhaps I'll come back at some stage in a year's time or in 2 years where we have piloted this to see, has it worked? Because it's not just a case of looking at who's going to do the products. And Evidence Synthesis Ireland, and groups like HICWA, indeed HRB's Evidence Centre, are all coming on board to work together to develop, to design, and see can they deliver products in 3 days, in 3 weeks, in 3 months. They're going to do it in peacetime with, I'll call it hopefully, artificial titles, maybe focusing on influenza or something like that. So that everybody is familiar methodologically with the look and the feel of it, what's working, what's not, and whether they're credible, they are trusted, and whether people use them. I think the more difficult piece on that is actually going to be that has to be delivered to somebody. So we're working with the department at the moment in terms of a governance structure. What would that decision making or prioritization or that governance group be in the event of a crisis tomorrow? We know what we did in COVID. What would that new governance structure be like? Who would this team, who would this hub be talking to? Who would make the decisions of what is a priority? And who would you be presenting the products to? So we're going to try and simulate all of that in peacetime, as it were. And I'll come back at some stage and maybe talk to you about that as a model for elsewhere. My final point just for today is I did want to just mention data, because it's not all about evidence synthesis, and data is king, no matter what area we work in, from a policy making perspective. And in health, we have vast and copious quantities of administrative data. What do we mean by that? Things like waiting list data, demand data, usage data, who's attending our services, do they come back, GP data. I could go on, prescribing, etc. And data access and linkage, the ability to access that data, to link it. To link it, you need to have an identifier, and I'm pleased to say that through legislation that was passed just recently in the Health Information Bill and further legislation coming through Europe, this is now starting to become a reality, not just something that we've been talking about for the last 10 or 15 years. This is definitely an area where we have been behind other countries, and I think in health we're not alone. I think this probably, I could say that with confidence across any and all sector. We've had fantastic work, and we have a great statistics agency, and a lot of work happening around data rooms and so on. But the ability to access and link data and then to provide it securely and in pseudonymized fashion to somebody is a game changer. And again, I just put some of the things there, but certainly from a health perspective, it's just not possible at the moment unless you're able to do that. And indeed to link it with other research data like Tilda. For example, being able to link that with administrative data would be a game changer. On the optimistic note, as I said, both our national legislation and the European health data space, which has to be enforced by 2029-30, is really driving a lot of work in this space. Certainly in the health space, and by health, for some of you who maybe work on the margins of, we fund population health, the broad determinants of health. So the classification of the types of data that need to be available to be shared and accessed and linked goes, I would say, broader than the health area. So something worth looking at, because again, things like housing, the life course from children to adults, etc. There's going to be a lot of data categories. And the department are leading a project with some co-funding from Europe, ourselves, HICWA, the CSO are working closely with them to actually design what will be a health data access body. In Ireland, it's mandatory that every member state is going to have one of these, so actually you'll be able to apply to other countries as well, to their health data access body, and you'll be able to link data from across other countries. And it will be like a permit system. You'll apply, you get a permit, the data will be accessed, it will be linked by the HDAN, who will then provide that to you on a secure portal where there is statistics, capability and so on, and you can do that. And this is a model that is really, really key to safe, lawful use for policy, but also for research purposes, and that's really important. So a lot happening around the country and around the world on secure processing environments, data lakes, and people getting organised, maybe at hospital or at a regional level with data lakes and so on, to be able to play with this. And a lot happening, a lot of this led by HICWA, already developing a metadata catalogue. You may have seen some news about that in recent times, where they put a draft of the metadata catalogue, because if you can't find it, if you don't know it exists, you won't look for it and you won't use it. I won't touch on this, but just basically saying a lot of work going on at government level, and particularly by the department on this, because it has very practical implications from a funding, a lot of infrastructure, a lot of work to be done around quality and harmonisation. The data you use is only as good as you use, so a lot of focus on quality and harmonisation, and certainly we will be playing a very active part in helping government and the department engage with the public around this, because this is sensitive, and we need to handle this right. It is a game changer for policy, for planning and for research, but we have to get the communication right. So I think that's something where we're pulling in the support and the expertise of public and patients, but also a lot of people with communication skills around the system. So that's something to keep an eye on. In conclusion, at this stage, I would say, I hope you've seen that investing in all types of capacity, capability, keeping people involved in methods research, making them aware of quality frameworks, driving and promoting open science is not just about publications, it's also about data. We'll never move to living synthesis if people don't publish their search strategy, if they don't have a portal specifically with the question they asked, if they don't have a portal with the data so all of these portals, platforms, repositories are something that funders and others are funding in terms of infrastructure at the moment. And then we've talked about people who can work closely with decision makers, people who understand context is important. And I think the more we are going to be working with international partners on AI-enabled living reviews, I think it's something that I would say for the research community generally and those in the synthesis space, much more focused now on not just generation of the evidence, that's what it tells us. What is the art and the craft of contextualizing international evidence for national and local decision making? So I think that's something that I see a lot of focus on. And then in conclusion, I think we focus on the research community, we focus on the infrastructure, we focus on the generation and synthesis. But as John mentioned, and I think it's something that Evidence Synthesis Ireland in recent years has started expanding their training courses and their workshops and their own skill set in terms of looking at the skills and the capacity and the tools that we can use for supporting decision makers to be able to access, appraise, and use the evidence. So I think and obviously the formats, the types and how we present it makes a big difference as well. But I think we do have a responsibility and we can contribute greatly, directly and indirectly to supporting those individuals who have the tricky job and sensitive job of adopting, not adopting, justifying, etc. And presenting it to ministers and to others. And I think a lot of focus needs to be doing that. So I think a lot of very positive things happening that I think are relevant in and beyond health. I think evidence synthesis and data are transferable across the board, and a shout out generally for more funding for the research community. Not thinking that infrastructure like this is dull. It's really, really important to connect, to collate, to coordinate. And they're really the three words that I'd like to leave you with. I'm happy to take any questions on it later on. Thank you.
Thank you very much. He said it's great that obviously Open Search Board is more than just a funder. It clearly is a knowledge broker as well, capacity development, and building out that evidence support infrastructure. So we've heard about the leadership in the Department of Health, the demand side for evidence. We've heard a lot about the supply side and supporting the national capacity for producing high quality, timely, accessible evidence. And the department has been brave enough to invite in, commission an independent evaluation. So it's not just talking about evidence use, it's commissioning evidence to inform how they want to build out their system. So it's being evidence led in terms of how it constantly strives to strengthen its own particular system. And now we're going to hear from Barbara Whelan, who led the particular assessment of the evidence support system in health policy in Ireland. To you, Barbara.
Super, thanks very much. It's nice to come after John and Teresa, although I've been waiting to speak, but it's nice to pick up on a lot of what they've said and stuff that we found in the RESA that we conducted. And a RESA is a Rapid Evidence Support System Assessment. I'm going to describe what the RESA is about, and just prior to that I'll just go through again, and John O'Connor picked up nicely at the beginning what an evidence support system is, what we mean by evidence, what the RESA involved, what we found, and what the recommendations were that came from that. So the evidence support system, and again, John mentioned in the introduction at the beginning about the evidence support system, provides the structure or framework that connects evidence to policy, essentially helping to get good evidence to inform good decisions. So we think of the evidence support system in terms of three different areas. So the demand side is the evidence users, the decision makers, policy makers, supply side, the evidence producers, research institutions, researchers, agencies, and then the intersecting part, the interface, connecting both the demand and the supply. And this is typically the knowledge brokers or evidence intermediaries. They're connecting research and policy, synthesizing the evidence, brokering, translating the evidence. And the RESA then is looking at each of these different parts and seeing what's working well and where there's room for improvement. And also then what do we mean by evidence? And again, you might remember one of Teresa's slides was a light bulb with 8 different forms of evidence. And really it's to highlight that there are different forms of evidence, and Teresa focused particularly on evidence synthesis and data analytics, but also there's guidelines, modelling, qualitative research, so lots of different forms. The RESA, as I mentioned, is looking at each of the different parts of the evidence support system in detail. And so, for example, on the demand side, where the evidence users, is there a culture that values the use of evidence? Do people have the capacity, and are the enablers in place for evidence use? So it's really just mining down into what's working well and where there's room for improvement in the different parts of the evidence support system. For the supply, how is evidence produced? Is there timely, demand-driven evidence? So if you think of a policymaker needs a piece of evidence in the next week, is it possible to get that so it's timely and it's also what they need? And the interface then is the connecting role. So again, do we have knowledge brokers connecting between the demand and the supply side? So we conducted a RESA. We followed a mixed method structured approach in our RESA, and it involved 2 key stages: a document review and interviews. The first, we carried out a targeted document review, focusing on documents that could show how evidence is requested, produced and used. So things like strategic frameworks, evaluation reports, committee terms of reference, evidence products. We then conducted 19 interviews with 20 stakeholders, and these were policymakers, evidence producers, knowledge brokers across all 3 domains. We then triangulated the data from the interviews and document review. This involved mapping themes side by side across demand, supply and interface to check for consistency and to identify gaps and opportunities for strengthening the system. Finally, we sense checked our findings with our oversight group and selected senior policy leads just to check, did it make sense for what they're experiencing in the department. Further details about our methods can be found in the paper we published in HRP research, and the citations there at the bottom. So what do we find? So when we looked at the demand side, with the evidence users, we looked at what's working well and where there's room for improvement. What came through clearly is that there's a strong commitment to evidence-informed policy making within the Department of Health, and I think already in the talks today we picked up on that, all the different things going on in order to facilitate evidence getting into policy. One interviewee described it as a bedrock of what they do, being very much evidence-driven. The department has a dedicated analytics capacity, and again, John O'Neill mentioned about the Research and Development and Health Analytics Division. And also then you've got economists and social scientists from IGs, and you've got data analysts from the National Statistical Service. So lots going on in terms of that capacity. Some policy areas have well-established formal pathways for evidence is consistently brought into decisions. For example, health technology assessments, screening and clinical guidelines. So there's direct links between getting the evidence that you need for the particular policy unit. But when we looked at the evidence, at how evidence use happens in practice across the wider system, we found variation. So day-to-day pressures such as parliamentary questions, legislation, briefing ministers means limited time for policy work. One interviewee observed that even finding an hour a week for policy development can be challenging. Skills and confidence in sourcing and interpreting and applying evidence also vary considerably across policy staffing, and there's no formal process for prioritising or tracking evidence needs. So again, strengths on one side and areas for improvement on the other. Excuse me. Right, on the supply side. On the supply side, there are genuine strengths. So there are diverse and credible evidence producing organisations like the Health Research Board, HICWA, and the ESRI, with strong national and international partnerships. There are structured pathways in key areas. So we already heard about the HIV Evidence Centre that has a direct link between the Department of Health and their evidence synthesis needs and can produce evidence synthesis for the department. We also heard earlier about the Evidence for Policy programme between the Department of Health and the HRB. And also the National Screening Advisory Committee, for example, has a clear link between where they can find the research they need, which would be typically from HICWA, and that can inform their screening strategy. There are also strong standards and structured products such as health technology assessments and evidence synthesis. But there are areas that need attention. So quality assurance across commissioned work is variable. It isn't always clear how evidence quality was assessed, which makes it difficult to judge the reliability of what is informing decisions. There's no shared repository or central tracking system for commissioned work. As a result, research is often commissioned independently across units without awareness of what has already been done, creating a real risk for duplication. Modelling capability is limited and fragmented. Expertise is spread across universities, and agencies are mobilised on an ad hoc basis rather than as a standing resource. Evaluation is also not consistently embedded, and again, Teresa hit upon that earlier, that sometimes interviewees described examples where efforts to include evaluation and met resistance, so the system can't always tell what's working well and again where we should be continuing to invest or possibly pulling back on investment on a particular programme. And data linkage remains a persistent challenge. So again, Teresa hit upon that around data, and often it's hard to tell maybe how many people have a particular health disease, for example, and that then links to issues around modelling. So if the data isn't there, it's hard to do modelling. On the interface, so the connecting role between evidence and policy, we saw strengths here, such as proactive knowledge brokers, percolating information to policymakers before formal requests are made. I liked that idea of this idea of meeting with policymakers, talking about projects that are going on either nationally or internationally. Possibly down the line, they might need that information or need the evidence from those projects. So it was just all the time, just percolating information and trying to maybe anticipate what they might need in the future. Also advisory groups creating structured connections, and research and policy conferences bringing researchers and policymakers together. So the Department of Health ran 2 conferences around coming out of COVID times, and it was a really good opportunity for policymakers and evidence producers to come together and chat. But there are gaps. The department currently lacks a formal mechanism to triage policy questions, match them to the right evidence, and log in quality assured options. The interface works mostly because of people rather than process. There are many points of collaboration and goodwill, but they're not yet joined up through a formal system. And personal networks are vulnerable to staff turnover. One interviewee described constantly having to rebuild relationships from scratch when policy staff move on. So it's that thing of needing those personal connections, but also needing to have a system behind that. That's, when that person retires or moves on, that there isn't a gaping gap there because of that. COVID illustrated both sides of this. Ireland showed it can mobilise rapidly when urgency demands it, but that capacity was latent or activated by crisis, not built into routine practice. The aim is to build on what worked and embed it into the system so it functions in normal times too. So when we take strengths and where there's room for improvement together as a whole, what we see is the picture is quite encouraging. The evidence support system for health policy making has all the right ingredients, such as strong evidence producers, motivated policy makers, and trusted relationships, but they're not yet connected into a single end-to-end system. So 3 cross-cutting themes really stand out. There is a commitment to using evidence. It's visible in strategy documents and in how people describe their work. The next step is to make that commitment consistent in day-to-day processes, so it isn't dependent on the individual units or individual initiative. There is reduction of and access to good quality evidence, but coordination is weak. Without a central place to prioritise, track or share commissioned work, there is a risk of duplication and missed opportunity. And third, personal networks are a strength. People trust each other and get evidence moving more quickly. The system is vulnerable if those relationships are the primary mechanism. Staff changes can mean having to rebuild connections and momentum from scratch. So we have framed our recommendations from the RESA into what we're calling 4 big moves. And the first is to coordinate and formalise, and this addresses the fragmentation we saw on the demand and supply side. So it means introducing a 2-track prioritisation process, 1 track for planned strategic evidence needs and 1 for urgent requests. We heard today, I suppose, about the focus on rapid evidence, and that's for the urgent request, but all the time as well, there is other evidence needed more long-term looking into the future. So it's to have a prioritisation mechanism for those 2 different needs. Also having a central repository where commissioned research is logged and reusable, and establishing a standing evidence synthesis hub that can be activated when needed. And again, we heard about the evidence hub through Evidence Synthesis Ireland that's been established at the moment for emerging health threats. The second addresses skills and capacity variation we found across policy units, so to build capacity and culture. This includes embedding evidence-informed policy making competencies into performance systems, having foundational training for policy staff and building evaluation as a standard, and expanding specialist analytical and modelling capacity through fellowship and academic partnerships. The third is building on the interface, so embedding knowledge broker roles with clear responsibility in regular research and policy forums. So again, encouraging that engagement between the demand and the supply side. Piloting a rapid response evidence service with a 10-day working turnaround and a more flexible procurement model for urgent, complex briefs. And finally, to ensure quality and accountability. Because without consistent standards and transparency about how evidence is used, trust in the system erodes. That means proportionate quality standards for different evidence types. And again, Teresa hit upon this a lot around the different thinkable quality standards and having them proportionate to the different types of evidence. Rapid research approaches to fill evidence gaps quickly, and frameworks so we can document our evidence-informed decisions. So in conclusion, Ireland has a strong foundation, committed leadership, skilled people and trusted partnerships already in place, but these strengths are not yet fully connected into a resilient end-to-end system. That's where our recommendations come in. We now have a practical and achievable pathway. Our recommendations taken together would help build a more connected, capable and trusted evidence support system for health policy making. Leadership commitment is essential for successful implementation. The building blocks are there, and the priority now is to connect them and to sustain the progress. So I think between the 3 talks today, it's obvious there's a lot going on around the evidence support system and for health policy making, and really is to keep that momentum, but also to be building the connections. So just to acknowledge, I mentioned an oversight group earlier. Our research was supported and guided by an oversight group that was convened by the Health Research Board, and we had representation from the Health Research Board, the Department of Health, the Department of Further and Higher Education, Research, Innovation and Science, and also Master Health Forum in Canada. And the research team is in Evidence Synthesis Ireland in Cockburn, Ireland. So thanks so much for your attention today, and happy to take any questions.
That's brilliant, Barbara. So I'll be able to look at especially kind of the recommendations and the generalizability of those recommendations for any institution interested in stress testing its evidence support systems or its research policy engagement type systems. So really fantastic stuff there. Plus the 3 presentations, and I'm sure something there stimulated your interest. Well, Mark has been following the online chat and will be able to curate some of the key points coming from there to the panelists. I'm going to go to the floor here first and just ask you if you have any questions, comments, observations on what you've heard, and just maybe just to declare your institutional affiliation at the start. So anyone wants to take it up to the start?
Thank you so much. My name is Emily Byrne here from the Local Government Management Agency. One thing that I notice about health research and treatment, you're the one that said it as well, is it's very evidence-based, it's very evidence-informed, and I think in that regard, health is so far ahead of some of the other social disciplines. And so sorry to start with a complicated question, but what would you say that other social disciplines or fields could learn from health in terms of making that step towards evidence-informed practice? Because I think it's in that knowledge sharing, but also linking together researchers and policymakers who have different understandings of what evidence might be. I feel they could learn something from how health has progressed. So what would you say about the challenges you've experienced in the field and what can you learn from them?
We just say to them, so while you're gathering your thoughts on that, why can't education and transport be more like health around that? And if you have any other questions on the floor just for now, maybe the 3 hours done. Nothing else there for now.
I remember the question.
Yeah, I think we have one from Sean.
Sean, I work with Mark and John. It's kind of building on that. How applicable is this whole partnership model? Which is, let's be honest, amazing, brilliant. It's very hard to pick holes in anything that you're saying or to overly think that there are big gaps, other than the ones that you're identifying just this moment. How applicable is that more broadly, and how do you, whichever of you had broader dialogue about the applicability of this more generally nationally, or indeed in outside of the health field?
Really interesting and important questions. I mean, first off, I think everything that we talked about here is, notwithstanding the culture and the history of evidence-based medicine, there's still been a lot to refine, to change and to learn, and we're all still learning in terms of evidence-informed policy making in health. Secondly, it's really important, even for health's sake, that all of those departments that you've talked about actually are on this same space, because certainly in terms of our perspective as a funder of population health, knowing what comes across the table in a ministry of health and social care, we're looking at social care, looking at social sciences, and looking at the broad determinants of health. So actually increasingly in terms of looking at prevention, in looking at well-being, in looking at avoiding, if you want to reduce it down to demand and waiting lists for hospitals, and having care in the right place, even from that perspective alone, the conversations are with housing, homelessness, with justice, around drug addiction, with Department of Children and equality across the life course, and I could go on, and social protection. You know, I think that is the thing in the world that we live in. I know it is an overused kind of, wicked challenges, complex challenges, but actually the things that we're really struggling to figure out, like, what the options, the scenarios, the trade-offs, and what will work best, and what will work best here, and work best considering where we're starting from, require those interdisciplinary and actually those cross-sectoral approaches. So that's just, I suppose, a little argument for the need for it, even selfishly, through a health lens. I think I was asked this question yesterday in an international forum. What probably made the biggest difference, or where would I start if you were starting from maybe a zero-sum game in the policy department? I would start with something like scoping reviews instantly, and either go to look, there's capability, there's capacity. You can train people. There are people with the skill sets who are working maybe in the health and social care space who can pivot undoubtedly to others. It's something that certainly in the HRB Evidence Centre, I know we've been approached increasingly by other agencies and government departments saying, can you do some of this for us? The reason I say that is the starting point of where policymakers who perhaps don't have a culture, a history, training this, is in the agenda setting part of the policy cycle. And so when I said that it's typically scoping reviews, where do I start? And you're looking at existing evidence in other countries and other systems and other models. There's something quite safe about that, if that's not the wrong word. It puts everybody at their ease having conversations about where you get evidence, what type of evidence is there. It gets them starting to think about their context. And gradually you see people in a policy context, and this is nothing to do with seniority, right, but maturing into having and being more comfortable in having an evidence and a research conversation, and they are learning on the go. And I don't mean this in a pejorative or a patronising sense, but it is genuinely, and they're short. They're usually like about 3 months. But you build that relationship, and what we found many years ago in the department, and other people, I want that when I'm starting my policy, and particularly with the turnover in the department. Actually, you've got a really good, solid piece of work that somebody who's then coming in can start with. That's a jumping off point, I would say. It is a confidence builder. It is something that you can then go forward with, because this is all about relations. It's all about trust. And it is quite daunting for a policymaker. I know from the time I was in the department, people used to be apologetic when I'd look to sit in their policy units or their meetings, and they go, we don't know anything about research. We've nobody in the team who's research experience. So I was like, you don't need to have. You have units now who can support you and guide you through in the department, and you have intermediaries and brokers or people who can sit. You're not expected to be turning yourself into an expert researcher overnight. So it's about people coming with the different skill sets, finding a safe place and something uncontested to work on in person. It's a bit of a simplistic answer, but I actually genuinely believe that is where I would start if I was trying to start building forward in a policy department.
And if John or Barbara wanted to come in on that piece around the generalizability, either on the research and policy ecosystem in health, or on the RESA maybe as an instrument in terms of the findings or the methodology, and how it could be used across lots of different policy areas.
Yeah, definitely. It's coming to mind the RESA, selling the RESA again, but it's a really good opportunity to just look at a system and to see what's working well. So whether the RESA could be done across government, it could be just done in like your own small department or unit, and it has been done across government. We decided to just focus on health policy making, which was very helpful, I would say, for the first time that the RESA was conducted in Ireland. But equally, there would be benefit for doing it across government and seeing that bigger picture of what's working well and that. But definitely, I think looking at a unit and thinking about, the culture, is the first one, do people value the use of evidence? And if that's something that needs to be addressed, or hopefully they do, but then let's move on and go, okay, the capacity, do they understand evidence? If they get a recent, an evidence report, can they understand it? And then also, can they actually even search for the evidence? Are there databases available to them? Is there access to a library? All of those really kind of simple things in a way. But it's a really good start. I think it's a good start to get your head into thinking about evidence and linking it to policy and what structures need to be in place for that.
Yeah, maybe, sorry to add quickly to that, but obviously you're in the LGMA, so you're probably coming out from the government point of view. And it's interesting that I mentioned Impact 2030, so there is that kind of meeting of all the government departments and agencies a number of times every year, the opportunity to share kind of what might be seen as best practice or elsewhere. And I think that's really interesting because it does kind of actually get that conversation going around around a more uniform approach to evidence for policy. and even including kind of RESA and talking about that and kind of and trying to kind of nearly socialise that more kind of across the system. And I think even to one of the points that Teresa mentioned, another key point within that group actually is around data and kind of thinking about kind of how we actually can pool our data, not just from the Department of Health point of view, but how we interact with other data sets across other government departments and agencies, and thinking bigger about that. And kind of, so there is that process there. It probably needs to kind of maybe kind of do more on the evidence side of things, but that sharing of information is kind of key.
Good question here.
Sorry, should have applied there. I'm Dr. Nicola Langford. I'm an associate professor in the School of Business here in Maynooth. I just have a question, I suppose, about qualitative data. We had Dennis Naughton here a little while back and talking about different forms of evidence that are used in policy making with a big P, and talking about how their politicians are constantly gathering qualitative data in their conversations with individuals. And I suppose I was struck by the sort of the absence, and I know it was on the slide, and I know it wasn't the agenda for today, but struck by the absence of any kind of plans to how we can incorporate robust synthesis methods and interrogation methods for qualitative, or even build the qualitative data sets in the first place. And I'm so concerned in healthcare policymaking in particular that we have a situation with qualitative data. It's one strong voice sitting around a table, one very sad, very moving story, one person. And we have such robust methods for gathering qualitative data, synthesizing qualitative data and communicating it, but they don't appear too strongly. So I was wondering if I would love to do a RESA, for example, that is specifically focused on qualitative data use in healthcare policy making, and see what kinds of data are being used by people to make decisions, where they're getting them from, how they're assessing their robustness, and what we can do to focus that going forward.
Do you want to say anything about the types of, because this did bubble up? I'm sure the whistle stopped here, but absolutely agree completely with your comment, but in the context of the rest, if there were.
Yeah, I mean, I think it's really interesting. I suppose qualitative data, you've got, people would have said, I think the qualitative data really sells something to a policymaker, actually, because I suppose it's that it makes something very real for them, which is slightly concerning as well, because you wonder, is it just that one story? And I think what we keep coming back to on the RESA is having those quality guidelines for all different forms of evidence. And so it's not just, a quote from one or two people or something, that actually, if we're qualitative data informing evidence, should be quality assured data, and it should be a quality assured qualitative study, for example. And that's really important. And, I think it's making sure that that's been requested. So if, somebody's telling you, I heard the story the other day, taking that for what it is, but acknowledging that's one story, and it's not acceptable.
I think important to also use this forum to say that the RESA report, the detailed report, will be in public domain shortly. So we're hoping that people will leaf through it, and so in early June, it will be available. And obviously, protocols and so on, Barbara mentioned, are available, but there's nothing like getting stuck into it. And you'll see things in there about things like maybe either in some instances not clear, was there qualitative input into the decision making, even where evidence was used, or in many instances actually really good efforts to pull disparate voices and groups together, but not at all clear in the policy document or in the report how it actually impacted on decision making. So there's sort of two things that come up in relation to that. I mean, I completely echo, which is why it was absolutely critical on the list of the different types of reviews in terms of synthesis, but again also learning in COVID times And I think this is something we're looking to the Canadians, to John Addison and the gang in Canada on this, because he would say, okay, look, so you can go through that wheel and you can look at all the different things and look at them in isolation and say, okay, for this decision we have this, or we have this type of evidence. Actually, when they talk about a rapid service and rapid products, they're actually talking about bundling what policymaker needs. Actually, we're not there yet, so we're definitely not there in health, even though we might be further ahead than others, which is actually an intermediary unit that basically engages with policy and in pretty quick turnaround pulls together perhaps a number of reviews of different types, qualitative evidence on the acceptability either from the public or people with lived experience or subsets thereof, perhaps feasibility, acceptability from the workforce that is supposed to, so a lot on the implementation, the acceptability, the context piece, and often a behavioural piece as well. So they would refer to the bundling in a product that they then give, which is, I mean, that's something that I think is ultimately, that's what a policymaker wants. They want, and even if they don't maybe articulate it as such, really that is what they want. I think we are still doing things perhaps in sequence or out to different groups. I think is probably where we've got to in health, including qualitative, but actually it needs to come together and be distilled and synthesized together, because that is ultimately what the decision maker is going to make a decision. So we have a bit yet to go there, but I think hopefully it will come out clear that this is really important, and will just echo your point. You want that with every single piece of other evidence that you're giving. You want that qualitative dimension, you want the information on the implementation context, and you want it on feasibility and the acceptability.
Thanks for another great question. And I'm just going to go to Mark Boyle, who's been following the chat, and see if there's anything there that caught his eye, and or alternative, as those familiar watchers and attenders of this seminar series know, that we go to Mark to see what caught his eye from the presentation and what impressed him, particularly from listening. So first of all, any burning issues coming up on the chat?
No,
if you haven't covered them off, maybe your own reflections on today.
yeah, we've got off John, and thanks to Barbara, Teresa, and John. The feedback has been fantastic. So the less questions and more. This is great. This is recording going to be available. Yes, the recording is going to be online in due course. And yes, it was great, and people with children in particular would like further conversation. More, so we get some great feedback back. My own observations, I mean, it's been fantastic, really good, and the order you've spoken worked really well. I think when we were planning this, we were thinking about what's the best order, and I think Barbara coming last to the round up, lassoed together some of the earlier stuff, I think brought the thing to a nice close. So why is health the forerunner, one of the forerunners in research for policy? And are we capitalising on the fact that we've got such rich learnings already banked in health that could cascade down to other units? Well, obviously it's a big department. It's a big spend. It's probably one of the biggest spend in the country. So that's going to make evidence-based more required. It touches us all. It's universal. We're all going to need the healthcare system at some stage, and families need the healthcare system, and it's life and death. So you can imagine all sorts of reasons why there's such a strong tradition of evidence-based policy. But it's interesting that it is, because that provides justification for other departments. In other words, if it's down to the money spent, and we want to spend that level of money in ways that are efficacious, then when we start spending money elsewhere, we should have the same kind of standard. If it's universal, well, other areas are equally universal. Climate change, for example. And if it's life and death, well, there are other areas that are existential for many populations as well. So the reasons that produce and drive the research for policy nexus to be so developed in the health system, I think is worth thinking about, and thinking about the replicability elsewhere. Can the Irish system, can the other departments learn from health? Clearly there's lots to learn. There's a need to decontextualise and recontextualise the kind of findings. I think Barbara's approach has tamed, really brought some order, really sharp, clear insights into how we might extract from the health those kind of lessons. I think there's beautifully elegant and simple but very powerful takeaways that you've identified, Barbara. So your approach itself begins the task of unpacking for other departments what might be of generic interest. For us in universities, evidence synthesis is something we don't really do. We teach our students lit reviews. So evidence synthesis has really been a new concept to me. And the spread and variety of types of evidence reviews are really stuff that we universities need to do more of. Data analytics, I think universities are switched on to, and clearly that's going to become more and more important as a takeaway. But several of you also mentioned modelling. And that got me thinking about the capacity in Ireland for modelling and what capacities we have, what capacities we don't have, what work we can't do in policy terms because we have a deficit in modelling capability. Why we have a deficit in modelling capability? We're a very software, IT savvy country. So I'd be curious as to think a little bit more about modelling and the resources, human resources that we've got in Ireland for modelling, and what we universities could be doing to produce more modellers. Two final points, then I will shut up. One of the things that it struck me, trying to think about what is bespoke to health that might give health opportunities, but also might limit the ability to learn lessons and transfer them, parachute into other departments. And that is the churn in this area. And you all mentioned this, how dynamic an area this is. We've just created a whole new school program of faculty of nursing here in Maynooth. The new program has been brought online all the time. AI in healthcare is growing data analytics and healthcare, new treatments, new staff, the churn of staff coming in and out of Ireland as Irish graduates leave to go to Dubai and so on. There's a whole kind of churn. That level of dynamism creates challenges for evidence-based policy, but I think it also creates opportunities because the inertia and the frictions in the system of doing the same again, status quo, is probably less entrenched in Ireland. And there's more capacity for change because the churn is so great, it's constantly refreshing itself. But what that does mean then is figuring the points of entry to a dynamic landscape has been moments of opportunity, and getting the training in now. We shouldn't be setting up a nursing school without having evidence-based policy at the heart of the design, the very anatomy of that school. You can't do that with pre-existing departments, but if you're setting up something from scratch, from the get-go, you can bake in and design it so that for grounds of production of evidence-based policy. So that's, I think that churn, newness, novelty, dynamism in healthcare makes it special and unique in many ways, but also opens up opportunities to actually produce a different way of producing evidence for policy by design. Finally, one of the things that I didn't get into was I always think that evidence for policy in healthcare is really good for clinical trials and pharmaceuticals and so on, and that's why it's done. We can't be 95% sure. I used to be 95% certainty confidence intervals, used to be happy with that, and then somebody told me, well, you take that drug and you get a 5% chance of dying if you so clearly you need robust gold standard evidence. And maybe that spilled over then to be evidence for health policy. Maybe evidence for health policy is vigorous because evidence for pharmaceuticals has been so important. It's created a culture within that department. But what strikes me in Ireland, and this is why I think evidence is so important in healthcare, is of all the departments, it's the most trickiest department to get change in. You know, I've heard ministers describe it as the Angola of the system. It's just so difficult, and it's because there's lobby groups, because there are interest groups, because evidence isn't oftentimes the main driver for policy. And I used to have these debates about whether cancer centres would be better having a small number, 8 centres clustered in particular areas, and that would generate more research expertise. But all the evidence says that's the best practice. But getting rural communities to agree to that is another ball game altogether. So because healthcare is so evidence rich, it also reveals insights into the limits of evidence-based policy as to, even if we have all the evidence in the world, where are the impediments to getting evidence into policy, and how do we navigate those lobby groups, those stakeholders, that complex political landscape of healthcare, which makes it very, very difficult to make the changes required, even in the presence of evidence. So there's something in the health case study, I think, that gives us lessons not only into what's gold standard or the best we've got in Ireland of producing evidence for policy, but there's something also about how difficult then even an evidence-based rich environment is in making the changes necessary to get us to where we want to go. And there's an impediment in health policy that I think merits some reflection and discussion, especially since we have lots of evidence for what needs to be done, but it's just so damn difficult to do it.
Thanks, Mark. As usual, really insightful observations there. Entirely my fault that we can't go back to the panel to keep the conversation going. And I have to bring proceedings here, especially online audience, to a conclusion. Obviously, people in the room can continue discussion afterwards. But it falls to me to thank Mark for those observations. Thanks everyone who turned up in the room today. Thanks to all the colleagues who joined online and participated and engaged in the conversation. And particularly a big thanks to our guests, Barbara, Teresa and John. Thanks very much. Brilliant contribution. We'll all be back again in the autumn with a further planned series of these Research for Policy episodes. So from Sean, Mark and me, bye for now. Thanks.
That sounded like a Ryan here.